So to begin with, the first important thing to note is that unlike the kidney, there is no anatomical change in the liver. The size of the liver remains normal. But all the liver enzymes, they are decreased during pregnancy except one, and that is alkaline phosphatase, which is increased during pregnancy. And why does this increase occur? Because apart from the liver, this alkaline phosphatase is also synthesized by the placenta, and this causes the serum alkaline phosphatase to rise. And this form of alkaline phosphatase synthesized by the placenta is a heat stable form of alkaline phosphatase. Now here we will discuss two important medical complications of the liver which occur specifically during pregnancy, and one of them is cholestasis of pregnancy. Now this cholestasis of pregnancy, it's also called recurrent jaundice of pregnancy or icterus gravidarum, and this cholestasis of pregnancy is mostly seen in the third trimester, but it may begin even in the second trimester. Now the basic pathology in this cholestasis of pregnancy is explained by its name itself. Cholestasis means stasis of the bile. That means the bile is incompletely excreted, and this is the reason the bile acids and bilirubin, both of them are incompletely cleared and they get accumulated in the plasma. So the level of the serum bile acids and bilirubin, of which mainly it is conjugated, their levels increase in the plasma, and because of the increase in this serum bile acids, it results in this most common symptom of cholestasis, that is pruritus, and this pruritus is more seen in the palms and the soles. Now coming to the bilirubin, their levels increase in the plasma, but the levels remain still less than 4 to 5 mg/%. Apart from this, the liver enzymes, that is SGOT, SGPT, they remain normal or might be slightly increased. The levels usually do not exceed 250 international units per liter, and the level of alkaline phosphatase is increased more than that in a normal pregnancy. Now if we talk about the order of appearance of the findings specifically seen in cholestasis, then usually the pruritus precedes the lab symptoms by 3 weeks. That is, first the pruritus will come, and then usually after 2 to 3 weeks the lab findings will start appearing. And among the lab findings, the first one to appear is dyslipidemia. So if you do a lipid profile in these patients, you will find increase in the LDL. And after this dyslipidemia, you can see all the other findings that we have already discussed, that is increase in serum bile acids, increase in the bilirubin, and more so that in the conjugated bilirubin. Apart from this, increase in SGOT, SGPT, which rarely exceed 250 international per liter, and increase in alkaline phosphatase. Now if we talk about the etiology of this cholestasis, the exact cause is not known, but associated finding is increased in this levels of circulating estrogen in these patients who have increased chances of developing cholestasis. Apart from this, there can be mutation of the MDR3 gene, which is specifically seen in the cases of progressive familial cholestasis. Now let's talk about the effects of this cholestasis on the pregnancy. Coming to the fetal complications, there are increased risk of preterm labor. Secondly, we have told that in this there is increase in the bile acid levels. So increase in this bile acid, it interferes with the function of the surfactant and thus causing RDS in these babies. There are also increased chances of fetal distress and meconium aspiration syndrome. And all these factors together, they increase the risk of the stillbirth. Now there is increased risk of stillbirth also seen in those females with bile acids level more than 40 micromole per liter. Apart from this, there is vitamin K deficiency usually seen in these cholestasis patients, and thus leading to fetal coagulopathy and intracranial hemorrhage risks. And in the mother, it can result in PPH during delivery. And this is the reason that vitamin K is routinely given to the mothers with cholestasis of pregnancy during labor and also to the newborns. Now coming to the management of this cholestasis of pregnancy. Now as we have told that in this cholestasis of pregnancy there is increased risk of perinatal morbidity and mortality. So these pregnancies should be monitored very carefully. These patients should usually be delivered by 38 to 39 weeks of pregnancy. We do not allow these pregnancies to prolong. And if they have associated jaundice also, that is the serum bilirubin level is higher, then those patients we try to deliver even earlier. Now, during the pregnancy, as I told you, the fetal surveillance should be done very carefully. The bi-weekly NSTs should be done, and as far as the mother is concerned, we give her antihistaminics to relieve her of pruritus. Emollients like lactocalamine can be given to apply over the skin. Cholestyramine can be given, but usually it is not used these days because they cause further decrease in the absorption of the fat soluble vitamins like vitamin K, which can again result into fetal coagulopathy and intracranial hemorrhages can occur. The next very important drug is ursodeoxycholic acid, and this is the drug of choice given in cholestasis of pregnancy, given in the dose of 8 to 10 mg per kg per day. This ursodeoxycholic acid, it not only relieves pruritus but also improves the fetal outcome. And in refractory cases of pruritus, plasmapheresis can be done and replacement with 5% albumin can be tried. And as I told you that it is also called recurrent jaundice of pregnancy. Why so? Because the chances of recurrence in the next pregnancy is almost 60 to 70%. And in patients who have a history of cholestasis of pregnancy, oral contraceptive pills should be avoided as a contraceptive measure. Now, coming to the another medical disorder which is specific of pregnancy, and that is acute fatty liver of pregnancy, also called acute yellow atrophy. Now, this is a rare condition, not very commonly seen, occurring in the third trimester, and the mean gestational age of occurrence is 37.5 weeks. And this acute fatty liver of pregnancy, it is the most common cause of acute liver failure seen in pregnancy. So, as the name suggests, acute fatty liver of pregnancy. So, this is characterized by microvesicular fat accumulation. Now, this is a mitochondrial abnormality which has an autosomal recessive inheritance, and the basic defect lies in the transport and oxidation of the fatty acids. Mutation occurs in few genes on the chromosome number 2 which code for the LCHAD, that stands for long chain hydroxyl acyl coenzyme A dehydrogenase. And as I told you, because of deficiency of this enzyme, there is disorders in the fatty acid transport and oxidation, and thus leading to long chain fatty acid accumulation in the liver, causing acute liver injury and endothelial cell activation. Now, this is seen more commonly in nullipara and with the male fetus. Now, let's come to the presentation of this medical disorder, and these patients, as I told you, usually present in the third trimester, the mean gestational age being 37.5 weeks, and they start with the non-specific symptoms like nausea, vomiting, anorexia, vague abdominal discomfort and malaise. And 1 week after these non-specific symptoms starts jaundice, which is progressive in nature. And 50% of these patients progresses to have features like that of preeclampsia, that is hypertension, proteinuria and edema. Now, as we have told that accumulation of this long chain fatty acid leads to acute liver injury and endothelial cell activation. Now, because of endothelial cell activation, there will be increased capillary permeability which will lead to hemoconcentration, and this in turn may cause renal failure. And this is together called hepatorenal syndrome. There may be also presence of ascites and sometimes pulmonary edema. Then again, due to hemoconcentration, the uteroplacental blood flow also decreases, and this will lead to fetal distress. And in this acute fatty liver of pregnancy, typically maternal leukocytosis and thrombocytopenia is present. That is, the number of WBC will be increased and the platelet count it is decreased. Now, coming to the lab findings that we see in case of acute fatty liver, LFT shows increase in serum bilirubin, but usually it is less than 10 mg per dl. In cholestasis, we told that the levels rarely exceed 4 to 5 mg per dl. In acute fatty liver, the levels rarely exceed 10 mg per dl. The liver enzymes SGOT and SGPT, they are also raised, but usually remain below 1000 international unit per liter. Level of alkaline phosphatase, it is moderately increased, and prothrombin time may be increased. Clotting time and bleeding time, they all increase. as the synthesis of the clotting factors in the liver is affected. Now coming to the renal function test, in this there will be increase in serum creatinine, which is seen in almost all the patients. Uric acid levels also increase, serum ammonia levels increase, the level of glucose decreases, that is these patients they usually present with hypoglycemia, and we are told that platelet count is decreased and the WBC increases, that is there is leukocytosis, and fibrinogen levels, if you get them done, then they are less than 100 mg per dl. And in severe cases, these patients have risk of going into DIC, that is disseminated coagulation failure. Now, how do we manage these cases? Now, once a case is diagnosed as acute fatty liver of pregnancy, then rapid delivery is advocated, irrespective of the period of gestation, because these cases are very fulminant. They usually progress very fast to liver failure, renal failure, the entire hepatorenal syndrome. So, rapid delivery is essential, following which the patient improves. And due to the associated coagulopathies, usually the vaginal delivery is preferred. We try to avoid cesarean section. But if the patient does not respond to induction of labor, then for rapid delivery, cesarean section is done. And as I told you that this is a very fulminant condition, the maternal mortality, it varies from 10 to even 75%. And once we deliver the patient, this hepatic dysfunction usually resolves. And there are two associated findings seen in the patients of acute fatty liver who have recovered, and that is transient diabetes insipidus and acute pancreatitis. And as for the fetal prognosis is also poor, and if these fetus survive, later they may develop Rye-like syndrome of hepatic encephalopathy and severe hypoglycemia. So with this, we come to an end of the liver changes seen in pregnancy. Thank you.